Genetics and heart disease. Where do we even start? Today, I sit down with Dr. Jessica Wang. She is director of the Cardiovascular Genetic Program here at UCLA. She's going to answer all of our questions regarding genes and the heart. I hope you enjoy my conversation with Dr. Jessica Wang. So as director of the Cardiovascular Genetics Program here at UCLA, what can you tell patients about genetics and their heart health?
So we all carry different versions of genes, and that's totally normal in the general population. And sometimes when there's an accumulation of specific risks, genetic change, and on top of that environment, sometimes that can lead to a diagnosis or cardiovascular disease. And we're here to help people understand what their genetic changes mean for their cardiac diagnosis.
Who is a good candidate for genetic testing when it comes to their heart?
So when it comes to understanding the genetic underlying of a cardiovascular condition, it comes down to what type of a problem it is. For some problems, we have a better understanding of the genetics, while other types, we don't yet have all the tools to understand it fully. Therefore, the common indications for genetic testing in our clinic include cardiomyopathy, arrhythmia, aortic disease, and lipid disorders. In some cases, genetic testing will identify specific mutations in specific genes that may require specialized treatment that is not given for the general cardiomyopathy patient. And so the example of that would be a Fabry disease patient who may present like a hypertrophic cardiomyopathy patient, but they may in fact be qualified for specific Fabry enzyme replacement therapy that may help their care.
So can you explain that a little bit further? So cardiomyopathy, how would a patient have any idea that they might have cardiomyopathy and to get genetically tested?
Individuals with cardiomyopathy may be completely asymptomatic, and they may live with the condition for many years, and eventually leading to symptoms such as shortness of breath, lightheadedness upon standing, which can progress with a lower extremity swelling, etc., or excessive fatigue with activity.
Something like cardiomyopathy, especially hypertrophic cardiomyopathy, I'm told is genetic. Is that correct? And what are the specific types of cardiovascular disease that we are known to be genetics?
So hypertrophic cardiomyopathy is like a poster child of a genetic problem. Out of the patients we test for hypertrophic cardiomyopathy genetic mutations, we may get a genetic yield of about 2/3. There's still about 1/3 that's what we call gene elusive. We cannot identify a mutation. Sometimes we can observe that even in families that are, know that cardiomyopathy runs in their family, but yet we still don't detect the mutation.
Now, you also mentioned genetic testing for lipid disorders, which would, I'd imagine, then lead to blockages in the heart and a heart attack. What type of testing should someone do if they have a family history of heart attack or blockages?
Coronary artery disease can be due to multiple genetic and environmental factors. So we all know like smoking is important, blood pressure is important, as well as diet in contributing to coronary artery disease risk. Besides that, on the genetic side, you have single gene mutations that can lead to coronary disease, and then you have something what we call polygenic risk that can also lead to coronary disease. Currently, in the clinical setting, what we can offer is genetic testing for lipid disorders that can lead to coronary disease or premature coronary disease. There is heavy research activities investigating polygenic risk score. So far, the polygenic risk score can perform reasonably well in individuals of European ancestry, but that result can be spurious sometimes in other ancestry groups due to the differences in primary data. And so that's an area that still needs more research.
Do you mind explaining to the layperson what is polygenetic risk score means to someone like me who has no idea?
And so we know that in any kind of biological process, there may be many inputs, right? So you can have protein A, protein B, protein C, D, E, and F, and they all contribute to a process. So in your arteries, for a cholesterol plaque to form inside the artery wall, there are many components that have to work just right for it to get inside. And those individual components are encoded in your genome. And those genetic variations that we find natural, totally natural in the population, contributes a small part or a bigger part to that whole vascular structure. Therefore, there are many genetic factors that can either directly or indirectly affect how easily someone were to develop coronary disease.
I'm curious, can you explain to me what is DNA and what are you actually testing when someone comes in and they get genetic testing done? What's the process?
DNA is the genetic material that encodes the building blocks for your body. And so a DNA is housed in the nucleus, and it is transcribed to messenger RNA, and which is then translated into protein. The proteins are the workhorse, and they're the building blocks of your cell and your tissues in your body. Genetic testing involves a donation of a piece of your DNA. And so we can collect it by taking a blood draw, or we can ask you to provide a buccal swab.
And there's no difference gathering it via blood sample or the swab?
Long answer or short answer? I guess the short answer is that there is very minimal difference. If you're doing genetic testing of your blood, you're testing the DNA of your blood, right? If you're doing genetic testing through a buccal swab, you're testing the DNA of the inner lining cells of your mouth. So if you're a patient that you've had a bone marrow transplant, your blood cells are made of cells coming from a donor. Therefore, it would not be accurate to perform DNA testing on someone who has had a stem cell transplant donated by somebody else.
Now, if there's a heart patient like myself who's watching this, who has children, and this patient has arrhythmia or potential cardiomyopathy, should they get themselves tested or should they get their children genetic tested as well? Or what are your thoughts on that?
So our approach is always, because there is uncertainty upon genetic testing, sometimes we may get some genetic changes or genetic variants that we don't completely understand yet. At this day and age, it is recommended that the affected individuals in the family get tested first. If they test negative on a gene panel, then there's no reason for their family members to get testing as long as they don't exhibit any sign or symptom of the same condition.
Now, I remember getting genetic testing done several years ago, over a decade ago. And I actually recently came to you all and you retested me. Can you tell me how genetic testing has evolved over that decade?
Genetic testing used to be not very accessible to patients because sequencing was very expensive, and also not many centers offer them. And then the last decade or so, what has evolved is that there is now more sort of investment by companies that believe in understanding the landscape of genetic mutations in human populations. And so they're investing this money to kind of understand what their market is and to understand, what types of problems are out there, what kind of therapeutic options we can hopefully provide through additional research. And so they have made the genetic testing more accessible to patients. At the same time, the way we call genetic variants and in terms of the classification of genetic variants has changed. In 2015, there is a set of guidelines that came out specifying what kind of evidence we need to take into account before we call a genetic variant as disease-causing. The reason for that is that prior to that point, genetic testing companies or labs, or sometimes academic labs, use different standards. And so you might see reports coming, if you have a report that is older than 2015, the results may not be accurate. And especially at that time, we didn't have large population samples to know whether something is truly rare or not. And so that all factors into the interpretation of the genetic variant. And therefore, with any results before 2015, we always do a double check on the NIH website to make sure that nowadays, how are those being called out?
How do you determine that it's a genetic variant? What does that actually mean?
We know that we have different variations in our genome. You can imagine your genome is a string of letters. We're all humans, so we're pretty much identical in every space except for a few that may have a slightly different version from person to person, and we call those variants. Most of the variants are probably benign. They, if they're tolerated in the population, they're not going to cause any problem. There are certain changes that can cause the the protein to be altered, yet not so severe that it, didn't end up being a big problem even before birth. And so we survive our genetic variants. We, continue on to be adults. And then sometimes these variants, problems with them don't manifest until later on in life.
At what age would you get tested for genetic variants when it comes to cardiovascular disease?
Of course, we offer it to people who are affected now.
Okay.
Therefore, whoever is affected with a cardiomyopathy, for example, can get genetic testing. Of course, the genetic diagnostic yield does vary depending on what other risk profile that person might have. If that person has a lot of high blood pressure, diabetes, and other sort of metabolic things, that could also lead to cardiomyopathy. In those patients, the diagnostic yield will be lower because it's likely other causes may have contributed to the cardiomyopathy. So in general, the younger person is, the more likely we're going to find a genetic test finding. The diagnostic yield may be higher in maybe people who are in 20s, 30s, 40s, and then it gets less probably in their 50s to 60s. That's when things start to catch up.
Can you tell me what a patient and their family might expect when they come to your clinic to get genetic testing?
After you're scheduled, our team will send you a family questionnaire. And so the idea is to have it filled out as completely as possible. It's not expected that you would know that information off the top of your head. And so I'm calling parents, siblings to find out more. Family history is helpful. If any family member has had a diagnosis similar to yours, it's helpful to get the primary data such as EKG, echocardiogram, or any imaging of you, or depending on the condition. And that is very, very helpful. As I mentioned before, because of the sort of genetic information sometimes will return uncertain, what we call phenotype data or the clinical data become very, very important. So as we try to sort of link the genetic information and the clinical information, we want to make sure that that link is certain and that we're sending the appropriate testing. That's number one. And also when the testing returns, we're interpreting the genetic test results appropriately. In the clinic session, you'll meet with our genetic counselors, and he or she is going to go through your sort of health history kind of briefly and also dig into the family history, confirming the relationships and also the history itself. And then the counselor will explain generally the condition again and then provide what we call pre-counseling, making sure that patients understand what the genetic testing is for, what are the pros, what are the cons, so that the patient can make an informed decision so that they can sort of anticipate when they get the results back how they might react to that results, whether positive, negative, or uncertain. It's about building expectations and ensuring that they enter into it well-informed.
Do your genes define you?
No, your genes don't define you. So in the case of family members that get genetic testing because their relative have been diagnosed with a cardiomyopathy or aortic problem and are found with a genetic mutation, now the family member has had cascade genetic testing to better understand his or her own risk of developing the same problem. In this individual, we highly recommend pre-counseling before they even get genetic testing because we don't want them to have regret in finding out information that they may not find helpful. So the best people to get that type of genetic testing, that cascade family member testing, are individuals that can use information as a way of empowering themselves and their care. That information can help them make decisions now, anticipating for the future. And also in that counseling session, we'll explain to them not all genetic mutations are deterministic. In fact, the vast majority of cardiovascular genetic mutations, because they're later in onset, they're not as what we call deleterious. They're not as deterministic in causing a problem. So you're born with your genes, but there's a lot of intermediary steps between your genome and your health. Part of that could be your lifestyle, whether you've been monitoring your blood pressure, what you've been putting into your body. And so all of those can contribute to the final outcome. In the clinic, I do follow a significant number of patients and their family members of affected individuals. They have genetic mutations that are more likely to be what we call penetrant, more likely to develop a problem later on. I will provide sort of an outline of how we might follow them. by measuring some biomarkers so that we know where they are at this step, and so that they can start on, potential treatment earlier on.
What can you tell that heart patient who has been advised to get genetic testing? However, they're concerned that the test results might be negative for their family.
Genetic testing is there as information for the patient and their family members for the hope that everyone's health can improve as a result. And so there's a part of sort of mental preparation about it, and also understanding that all of us have genetic variations, and it's just part of being a human being. And it's not a curse. It's not that we did something wrong, and it's not that our parents passed it to us and they did something wrong either. These mutations weave in and out of populations and through generations, and it's just part of life. Understanding exactly which mutation caused the problem has many potential benefits. One is that you can then use, if your family members or siblings or children would like to know their risk rather than being blinded to that information, they can have an early insight into what could potentially happen so that they can seek monitoring and help more regularly, rather than having heart failure develop and then your therapies may not be as effective anymore. Another big side of it is really the development of therapeutics. So by understanding how genetic mutations impact the function of a protein and how that change in that protein affects the function of the cells in the heart, have enabled scientists to identify ways to correct that problem. And so the more we can have the collections of mutations in the population, the more we can understand the areas of need and also potential ways to address them. The first example of this would be hypertrophic cardiomyopathy, where now we have the first targeted therapy in cardiology, directed at cardiomyocyte. And that all came because of genetic understanding of individuals and families with hypertrophic cardiomyopathy, and the understanding of the mechanisms that led to the heart wall thickening and the downstream arrhythmia and heart failure symptoms. And by understanding that hypercontractility is the underlying mechanism of the problem, scientists have been able to design the specific inhibitor that are now available since 2022 to a specific subset of hypertrophic cardiomyopathy patients to improve their symptoms, their biomarkers, and there is a large potential of it being disease modifying, reversing the effect of heart wall thickening that we're all now observing in our clinics. And so there's a lot that's going to happen. Now the next step is to study the effect of that same medication in the non-obstructive hypertrophic cardiomyopathy group. And there are several other pipelines now, continuing design targeted to different genes and different gene groups by understanding the mechanism behind how genetic mutations cause disease and help disease. Actually, in a specific case in transthyretin therapy design, they actually discovered there's a favorable mutation in that gene that helped them design therapy to mimic that mutation that protected some family members in this devastated family tree, that they're somehow protected. And by identifying why these individuals were protective transthyretin mutation effect, that they're able to design a therapeutic to mimic the natural mutation found in population. So that's the cool thing about genetics, that the nature is a natural experiment. Mm-hmm. And so if you're able to kind of harvest the insights from the human population, you can then design ways to kind of correct some of the mutations in some families, yeah.
What is the financial burden that a patient might expect from getting genetic testing? And does insurance cover it?
We have definitely seen insurance covering. It really depends on the insurance. The out-of-pocket costs from the testing companies, sometimes they'll say that if the insurance does not cover, they will not charge the patient more than $250 or depending on the company, the maximum out-of-pocket cost. There's also additional options called sponsored testing, where the testing is covered by investors are interested in sort of drug therapeutic development that they may be interested in identifying how many patients are out there with a specific type of gene mutation, for example. They will not get patient-specific data from the genetic testing service, but they might get patient counts for how many patients. And so for that reason, they think it's worthwhile to invest in testing for patients.
You are a trained cardiologist, but also a geneticist. Can you tell me more about your background and how you became involved in genetic testing with cardiology?
Sure. I joined training at UCLA as a cardiology fellow, and within that program, there's a component research that is formal, and I did a PhD training in human genetics.
So tell me, what is your favorite part of being a genetic cardiologist?
What's interesting about this field is that you're very much directly tied to science, right? Once you identify a mutation, and that's where the potential for therapeutics very directly comes, right? So right now we treat cardiomyopathy, all the same medications. And those medications do work really well for dilated cardiomyopathy, right? And it's because they hit as sort of the common pathway. But now we're discovering that among the dilated cardiomyopathy, there's a subgroup called the arrhythmogenic cardiomyopathy. Interestingly, the diagnostic criteria keeps on getting revamped in the last few years. Even 2024, there's a new one from European task force that revamped it again. So it's definitely a moving target, very much. So the arrhythmogenic, I don't think you have the type that I'm thinking of, that have a lot of scar in the heart on MRI. And those are not very responsive to the general guideline-directed therapy that we give to dilated cardiomyopathy patients, and they'll just progress regardless, it seems. And so it does seem like that type will need very specific targeted treatment in order to make a difference. So, and the other side of this discipline is that it's really super fun to talk with family, right? And people get really engaged, they really care.
So I coined the phrase heartquake, or trauma of the heart, because being a heart patient myself and an advocate, so many of us feel shame and blame when it comes to our diagnosis. What can you tell me about your thoughts on the word heartquake?
To be diagnosed with a sort of potentially devastating heart condition can be kind of earth-shattering. As providers, sometimes we, fail to kind of relate to that. And we're kind of focused on, what do we need to do now and next? And so thank you for sharing that thought, and that really made me think. Yeah. But in terms of how we conceptualize genetic variants in our human health, because of my background in studying population genetics, and variation is inherent in nature, and we all have variations. And it's not really our fault to be carrying variants, right? We're born with them, or that maybe there's a mutation that happened between generations. Your life or your genetics is just the hand you're dealt. But whether you win the game or not still depends on how you play the game, right? So if you use that genetic information, now it's open in front of you instead of in a pile that you cannot see. Now you have it open in front of you to the extent you cannot see everything because we don't understand everything yet. But to the cards that you can understand, hopefully is one way for you to kind of feel empowered so you can strategize your life according to knowledge, rather than having knowledge be an impediment to help. And so to the extent that it will help you, use that to help you. And so definitely we don't think that genetic testing is for everyone, right? We don't want to force it upon anybody. Even for people with genetic mutation, for example, it's not really our job to tell someone whether they should have kids or not. It's a very personal choice. Right? That's all just information. And as a physician, I'm really interested in how we can correct that through therapeutics. And if we can identify more and know more and how genetic mutations affect this family and that family, and find common themes, and how we can, as a community, start finding more specific and more effective treatment for these individuals where maybe our current tools are not adequate yet.
Thanks for watching Heartquake Media. Make sure you check out our website and social media for more information on heart healthy living. And remember, wellness starts with the heart.